Good afternoon, everyone, and welcome to today's session. 28th December, 29th, 30th, 31st, 1st, 2nd, 3rd, 4th. Very good, 5th. Still we have about 8 days time, right? So, Abhi Daktar, Vani, Muslim Haider, Nagredi Saab, everyone, welcome to today's wonderful afternoon anesthesia with Dr. Murli. So, doctor, if you look at the FMG exam, last 15 years there are about 100 MCQs in anesthesia after we remove all the repetitions. So we have done a quick analysis as to what is the pattern of those occurrence of the questions. Good to see Priyanka, for you. Anesthesia, this session is dedicated to Priyanka. On your request, आपके अनुरोध पे, right? Now, out of these 100 questions in FMGE, MCI screening test, there is a pattern. Local anesthetics, 13 questions were there. Muscle relaxants, 11. Then intubation, inhalation anesthetics, succinylcholine, CPR, different types of cylinders, colors, spin index, etc. Ketamine, epidural anesthesia, opioids, thiopentone. कितना हो गया? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 topics revision करने के लिए कितना देर लगता? Not more than 3 to 4 hours. And from this 11 topics only, frequently questions are repeated in the FMG exam in the past 15 years. So, doctor, let us finish these questions. And Rohit Kumar, sir, UPSC Combined Medical Services, 402nd rank आ गया. I am sending you the screenshot. अरे वाह, हम बहुत खुश हैं. It is all your effort. What is the common thing between a coaching guru like me and a obstetrician? Labor आपका है, credit हमारा है ना? Labor आपका है, credit हमारा है. So Rohit should be really give the credit to all our classmates, Nagreddy, Jagadishwari, Satya, Priyanka, everyone who every day participate in this interactive session for a couple of hours. We keep meeting across the year, and that is the source of becoming something to achieve, right? So let's hope the same good news you will be giving me once the NEETPG exam is over. Now, doctor, local anesthetic causing methemoglobinemia. This was a question of the FMG 2018. Benzocaine, even prilocaine. So, what are all the drugs leading to methemoglobinemia? You have to be 100% sure. You should be 100% sure on the list of the drugs. Dapsone, benzocaine, even lidocaine, prilocaine also, and methylene blue, chloroquine, even lignocaine. That's right, Priyanka, you're right. Even lignocaine, that was there in the options, but benzocaine more commonly. Benzocaine more commonly than lidocaine. Lidocaine only at very high doses, methemoglobinemia. Then amyl nitrate, nitroglycerin, primaquine, sulfonamides, they can lead to the development of methemoglobinemia. is what you have to basically remember. Very good. Priyanka is giving a very good below poverty line ko yaad rakhna methemoglobinemia ke liye. Benzocaine, procaine and prilocaine, benzocaine and lidocaine can lead to development of methemoglobinemia. Now doctor, which fibers? Keep punching the answers, doctor. Which fibers are mainly affected by local anesthesia? So, we should remember, it is the A delta fibers. A delta fibers. So, you should remember, you have A alpha, A beta, A gamma, A delta. If you look at the susceptibility to the local anesthetic block, alpha, A alpha are heavily myelinated 1 plus, beta 2 plus, gamma 3 plus, 2 plus, but delta jo hai na 3 plus. That is what you need to basically remember. Whereas type B, they are preganglionic fibers, they have a light myelination and they have 4 plus susceptibility to local anesthetic block. Then type C fibers, they are for the pain and they also have 4 plus susceptibility to the action of the local anesthetic block is what you need to emphatically remember. So, ये जो टेबल है ना डॉक्टर, उसका एक फुटवा ले लो, दिल में लगाओ, एग्जाम को जाना, याद रखना. That is very, very important. Okay? So, this is also once more. Alpha, beta, gamma, delta. Alpha is for proprioception motor. A, beta is touch and pressure. Gamma is muscle spindles. Delta is pain and temperature. Typically, their myelination is quite high. But within them, the delta is more susceptible. A delta. Then type B is preganglionic autonomic. It has a light myelination and 4 plus susceptibility. So you have to be 100% sure always. Come on, keep punching your answer, doctor. How does a local anesthetic basically act? What does it block? Is a very important question of the examiner. Good to see 50 online students. 50 online students. Very good. Guru Prasad is proposing sodium channel. Guru Prasad, you are from which part of the Telangana or Andhra Pradesh? We have a very top physician in Hyderabad called Guru Prasad from All India Institute of Medical Sciences. Excellent guy. Rarest diagnosis be you like a fisherman, he'll catch the fish. So very good. Guru Prasad is from Mysore. Good to see. Please tell all your classmates to join Guru Prasad from every day. We have a 2 hours of session, free live broadcast on the YouTube. So very good. I can see most of you saying sodium channel. Absolutely right, doctor. A time-dependent, voltage-dependent sodium channel ko local anesthetic will basically come and bind and block is what you have to remember. Once more, local anesthetic blocks sodium channel. Abhi aa gaya favorite question of the examiner. Ester group, amide group, which local anesthetic belong to which group is the favorite question of the examiner. So tell me, doctor, which is the ester group of local anesthetic? Come this. Which is the ester group of local anesthetic? Is there any clue for you? So is it? Yeah. Punch your answer, doctor. Punch your answer.
C. It's C. Students.
No, it's not benzocaine. Is it benzocaine? Oh, it is dibucaine. Dibucaine. See, how many I's are there in chloroprocaine spelling? 1. Tetracaine, how many eyes are there? One. Benzocaine also, how many eyes are there? One.
So of course D is the answer.
That's right. Only dibucaine has 2 eyes. Okay? Good. Now, you need to remember amides. They have lidocaine, mepivacaine, bupivacaine, prilocaine, ropivacaine. 2 अंक जो होता है वो होता है एमाइड और 1 अंक होता है वो होता है एस्टर is what you need to basically remember. So procaine, chloroprocaine, they're all basically esters. So benzocaine, chloroprocaine, cocaine, procaine, tetracaine, they're all esters. Only 1 I in the spelling. इसी बात के ऊपर एग्जामिनर रेगुलरली पूछता है which is an ester. So what is your answer, doctor? Chloroprocaine. Which is an ester? Procaine. These are all esters except prilocaine because it has 2 I's in the spelling. Now, what is the most cardiotoxic local anesthetic? Bupivacaine is most cardiotoxic local anesthetic. So doctor, bupivacaine के बारे में 5 बात बताओ मुझे. There is no topical effect. Bupivacaine has no topical effect. There is no bupivacaine ointment. It has a slower onset and one of the longer duration agents, 8 hours. Bupivacaine बहुत लंबा रहता है. It is used for infiltration anesthesia, spinal, nerve block, epidural anesthesia. But what is that unique property of bupivacaine? Bupivacaine का महत्व क्या है? Special feature क्या है? It leads to analgesia. It relieves your pain without a significant motor blockade. That's what you need to remember. Very good. Priyanka adds a very good point. Bayer block में bupivacaine नक्को देना. Good, good. Excellent, doctor. Keep punching some points that come to your mind. The whole purpose of combined study every day, a couple of hours, 1 to 2 hours, we have a live broadcasted session interactively so that you are motivated to study. That is most important thing. Right, doc? Now, high lipid solubility, high distribution to tissues, and less presence in blood, they're all good for the fetus. If you happen to give bupivacaine, is what you need to remember. But it is more cardiotoxic than other local anesthetics. It prolongs QT. It prolongs QT interval and lead to polymorphic ventricular tachycardia, torsidis, depointus, etc., etc. So how do you give, doctor? 0.25%, 0.5% injection of bupivacaine. So you have bupivacaine, which is used in nerve block, epidural, spinal. It is more sensitive than motor block, least placental transmission. So you can use it for painless delivery. It has an intermediate onset and it should not be used in IV regional anesthesia. That's what our Priyanka is reminding you, doctor. You can't use it in IV regional anesthesia, intravenous regional anesthesia like a Bayer's block. You can't use bupivacaine. One more place where you can't use bupivacaine. Obstetrical paracervical block anesthesia. That is one more situation where you cannot use the bupivacaine, is what you need to remember. So doctor, please inform all your classmates in the WhatsApp, Telegram and phone करके बुलाओ, ask them to join this quick revision. 100 hottest questions of the FMG. Don't think FMG is an easy question bank. No, doctor, there are a lot of tricky questions in FMG. FMG is conducted by the same board which is also conducting NEETPG. So it is worth doing a revision of FMG question bank. So totally there are 10,000 questions in FMG exam in the last 15 years. So please inform your juniors preparing for entrance. January 6th onwards, we are starting our journey towards 2021. So from January 6th to June 30, we finish revision of these 10,000 MCQs of the last 15 years FMG question bank in our daily live online interactive sessions. Then from July 1st to November 30 this year, 2020, we'll be finishing last 15 years PGI, very good question bank. Topic wise classified, and we will do a discussion. In addition, every Sunday there will be a grand test according to a schedule, and every Saturday there is a subject test and discussion, right? And from every year, December 1st to January 4th, every day we have a full-scale grand test and discussion, 34 grand tests and discussion additionally. So now we are running a quick, highly discounted early bird. So tell your juniors they don't need anything else but only Dr. Murli Bharadwaj. Let them join 9000-868-356 is our helpline for you to subscribe in onlinembbs.com video library. Once more, in the onlinembbs.com video library, we have already 2 lakh PowerPoint slides, 30,000 MCQs, topic-wise classified and discussed, 3,000 video lectures of almost 1,000 hours duration, both theory and MCQ based review videos. So everything is available. Additionally, we also have a supportive live interactive session happening through the YouTube. So that is the whole idea. Now, doctor, how do you use lignocaine? 2% jelly, 4% injection. So you should remember, lignocaine is most commonly used local anesthetic. In ophthalmology, 4% topical, 2% infiltration solution. It has a very quick onset of action, high degree of penetration. It is for topical, nerve block, infiltration, epidural, even for dental analgesia. So lignocaine is the one which is used. And what is the maximum dose, doctor, for the lignocaine? One of the favorite questions of the examiner. With epinephrine, 7 milligram per kg body weight for adult, and it should not exceed a dose of 500 mg. And 4.4 mg per kg body weight without epinephrine. That is what you should emphatically remember. So how does it basically act, doctor? Lignocaine. It alters the depolarization in the neurons by blocking the fast voltage gated sodium channels. And if you have given lignocaine, the presynaptic neuron will stop depolarizing, and hence it fails to transmit the action potential which is responsible for its anesthetic effect. So that is what you need to basically remember. EMLA. Have you heard of it? EMLA. What is EMLA? Eutectic mixture of local anesthetic. Eutectic mixture. What is the meaning of eutectic mixture? It lowers the melting point of two solids when they are mixed. Lidocaine, prilocaine at 25 degrees. The oil emulsified into water to form a cream. So that is eutectic mixture. So EMLA mein, what are the two things combined? Favorite MCQ of examiner, lidocaine, prilocaine. That is what you should remember. So this is how lidocaine 2% अगर cream है तो 4% अगर इंजेक्शन दिए तो याद रखिएगा ना, आप ये देखे तो भूलेगा नहीं. 2% lidocaine hydroxychloride jelly is what you should remember. Now, doctor, what is the shortest acting spinal anesthetic? Lidocaine. Out of this. But otherwise, you should know very well what are the three most commonly used local anesthetics in the spinal anesthesia, doctor. Lidocaine, tetracaine, bupivacaine. Lidocaine provides a short duration of anesthesia, mainly for surgical, obstetrical procedures which require less than 1 hour. Now comes the favorite batti marne wala cheez aa gaya. What is that? So every subject, doctor, every topic, there are few things shamelessly we have to by heart. Batti marna padta. There are some logical points, twists बोलते हैं हम, उसको twist बोलते हैं. So twist भी पता चलना चाहिए. List रहता. So batti, twist, list. These three things on every topic, all 953 topics. The moment you are able to achieve, nobody, no force in the world will stop you from becoming the topper in the tomorrow's NEETPG exam, doctor. I'm so happy to find the news of achievement. Rohit getting 402nd rank. Dekho, doctor, I'll tell you. First rank, second rank, third rank or up to 200 ranks, tension नहीं है. जिस लोगों को टॉप 200 में रहते हैं, कोचिंग हो या नहीं, कुछ भी हो या नहीं, उसको सीट मिलेगा. Because they are all highly self-motivated and committed stem cells. उनके लिए मेरा फिक्र कुछ भी नहीं है. Those who stand from 200 to 2000 ranks, no, they are the ones who are really helped out by any coaching, mentoring or any program. Because from a sub-threshold level, because of the daily live online interactive discussions like this, they could come to the threshold level and could fire an action potential. So that is the reason always, similarly, primary health center doctors, government doctors, those who left medical college 5-6 years back, they are all very close to my heart. Because if I can really help them to grow one step above from sub-threshold to threshold to action potential, I am really accomplished in achieving as a teacher, right? So that is the spirit, doctor. Rise up yourself from that sub-threshold to threshold to action potential. That is our today's sermon on the congregation that we are having, right? Now, doctor, low potency, short duration, procaine, chloroprocaine. Intermediate potency, intermediate duration, mepivacaine, lidocaine. High potency, long duration, tetracaine, bupivacaine, ropivacaine. This is what you need to remember. Out of these, 3 of them are called fast onset. What are they? Chloroprocaine, mepivacaine, lidocaine are considered to be fast in onset. Similarly, there is also a duration of action. उसके ऊपर भी ध्यान देना. 30 to 60 minutes is the duration of action of chloroprocaine is what you have to basically remember. Now, doctor, first generate sensation to be lost if you apply local anesthetic. Come on, punch your answers, doctor. Let me see how good you are doing. Very good to see 75 online students. Day before yesterday, our radiology video almost crossed 3,000 views. I am so happy. And also, 3,000 views means 70% views have watched more than 1 hour. That is a real achievement, right? So please tell your friends that YouTube चैनल पे ऑनलाइन एमबीबीएस का YouTube चैनल पे बहुत मुफ्त में मिलता है. उसके ऊपर से motivation is something, inspiration is something, and a classmate. I love to be your classmate every day and study along with you. Come on, punch your answer, doctor. Temperature, clean bold. Most of you thought temperature. Oh, no doctor, no doctor. Pain. Pain is the first sensation to disappear, followed by sensation of cold, warmth, touch. Last is deep pressure. Please don't forget. That means I could give a correction to a significant number of you who are attending today this session, right? कल के एग्जाम में नीट पीजी में यही क्वेश्चन आएगा. सिंपल क्वेश्चन है. आप टेम्परेचर आंसर करें तो और कितना नुकसान होता. So longest acting local anesthetic. Bupiva came out of all this. Now that is a short story of local anesthetics repeatedly asked in the MCI screening test. Next comes the muscle relaxants. Hoffman's degradation. You don't need liver, you don't need kidney. Still the drug is eliminated by a non-enzymatic degradation which is called Hoffman's degradation, non-enzymatic degradation. It is seen in metabolism of atracurium. So what you should remember, atracurium के बारे में 5 pearls बताओ. Non-organ dependent elimination, non-specific esterase, 60% elimination is by non-specific esterase. Hoffman's elimination, it is a spontaneous, non-enzymatic breakdown at physiological pH, is what you need to remember. At high clinical doses of atracurium, एक दिक्कत है. क्या है? It causes release of histamine that lead to hypotension, tachycardia, bronchospasm. Then atracurium's metabolic byproduct or end product is laudanosine. This laudanosine is a dirty fellow. It leads to central nervous system excitation. It can precipitate seizures. That's the point you need to remember. And those who are acidotic, hypothermic, then that will make the pH sensitivity of atracurium to prolong. That is, the action of the duration of action become prolonged if it is a hypothermic or a acidotic individual. That is a caveat that you need to remember. So ester hydrolysis, Hoffman's degradation. These are the two things. Physiological pH and temperature में spontaneous non-enzymatic chemical breakdown is called as Hoffman's degradation, is what you need to remember. So atracurium, onset is 3 minutes, duration is 25 minutes, histamine release leads to hypotension, non-cumulative, and what else? Even if there is a renal failure, even if there is a liver failure, आराम से आप atracurium दे सकता. So you can give atracurium even in renal failure and liver failure, and even in the people who have plasma cholinesterase deficiency. Certain communities of people have plasma cholinesterase deficiency. So typically in Telangana, Andhra area, Vaishya community is considered to have plasma cholinesterase deficiency. Sometimes that can lead to prolongation of the action of the atracurium as a muscle relaxant. I mean, succinylcholine as a muscle relaxant. Even in those people where succinylcholine contraindication is there because of the plasma cholinesterase deficiency, atracurium can be used, is what you need to remember. So, the intubating dose is 0.5 mg per kg. Those who have renal hepatic dysfunction, it is the drug of choice. About 82% of it is albumin bound and it leads to histamine release. Tuck, 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 like a AK-47 bullet firing. You should do the revision in the last moment. A 60-year-old patient undergoing surgery has a serum bilirubin 8.9, serum creatinine 1.9, kidney भी fail हो गया, liver भी fail हो गया, फिर भी कुछ, which is the muscle relaxant which you can give? You can give atracurium. That's what you should remember. Which is the fastest non-depolarizing muscle relaxant, doctor? Rocuronium is rapid like a rocket, is what you should be remembering. So rocuronium, it has a fast onset, intermediate duration, minimal cardiovascular side effects. Very good. Cardiologist is happy guy. Onset and duration is prolonged in elderly and a slight decrease in elimination in renal failure. And potency wise, vecuronium is more potent than rocuronium. So these are few things. Mainly you should remember fast onset. Rocuronium is like a rocket when it comes to onset of action, is what you need to remember. Now doctor, quickly tell me, what is the classification of muscle relaxants? Depolarizing blockers, non-depolarizing blockers. Other way around. Non-depolarizing are competitive, depolarizing are non-competitive. That is what you should basically remember, right? Now, succinylcholine is it will take a false identity. By my acetylcholine हूँ, चलो बोल के जैसे acetylcholine depolarize करेगा, ये भी depolarize करेगा नरु को. Then when actual acetylcholine comes and want to depolarize, it can't because it is already depolarized by succinylcholine. So succinylcholine does not compete acetylcholine. It will basically do depolarization even before acetylcholine comes. Hence it is non-competitive depolarizing blocker. Whereas if you take curare derivatives, pancuronium, pipecuronium, they don't depolarize, but they are competitive. हटो 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 बोल के उसको हटा के ये जाके वहां बैठ जाएगा रिसेप्टर के ऊपर, right? So that is the problem with these curare derivatives. So long acting are pancuronium, pipe, long pipe, pipecuronium. Intermediate are vecuronium, rocuronium, atracurium. Short acting is mivacurium, mivacurium. Remember, minute. Minute means small. Mivacurium is short acting, is what you have to ultimately remember. Now, which is the shortest acting non-depolarizing muscle relaxant? Mivacurium. Mivacurium, fast onset, short duration, metabolized by pseudocholinesterase. This is an important point. Generally, curare derivatives are not concerned with the pseudocholinesterase. But mivacurium is a curare derivative metabolized by pseudocholinesterase. Whatever, kya confusion hai bhai? Generally, succinylcholine means it is through cholinesterase. But mivacurium is a curare derivative, but metabolized by pseudocholinesterase. That is the fix. Twist. Examiner पूछने वाला twist यही होता है. It is fast onset, short duration. Pancuronium, long duration, it can lead to tachycardia. Vecuronium, intermediate action, fewer side effects. That is beauty about Vecu. Vecu is very good. No histamine release, no ganglionic blockade, no antimuscarinic action. Mera Vecu, very good. Because it has very fewer side effects. Though it is quite potent and intermediate in action, duration of action is what you need to remember. Which is longest acting neuromuscular blocking agent? Doxycycline. So pan is there, pan is also long one. Pan, pipe, doxa, they're all long, but longest of all is doxa. So if you look at the pancuronium, onset of action is 3 to 5 minutes, 1.5 hours it will prolong. It is long acting, and pancuronium only slight increase in BP. It undergoes hepatic renal metabolism, but it leads to histamine release. Vecuronium, intermediate acting, and primarily biliary excretion, secondarily renal excretion. So that is the reason it does not require dose reduction. Then Vecuronium, very good because histamine release ये पूरा गंदे गंदे चीज़ा नहीं करता Vecuronium, इसलिए it is very good is what you need to basically remember. Maran is asking, sir, if you prepare a list of CD markers, that will be great. Already we did that. अरे Maran, आप ऑनलाइन MBBS CD मार्कर्स बोल के टाइप करो YouTube सर्च में, हमने गर्मा गर्म निमोनिक बना के दिया आपको याद रखने के लिए. There are almost 1900 free videos in the youtube.com/onlinembbs. आज का लोग हैं क्या, हम जमाने के लोग हैं भाई. 20 साल से पढ़ाई दे रहे बच्चों को, almost quarter century, right? So we know what are your uncertainties. We know what you don't know, right? So online MBBS CD space markers बोल के टाइप करो YouTube सर्च में. डॉक्टर मुरली भरद्वाज का आत्मा दिखाएगा आपको CD markers को how to remember, right? हाँ. Rocuronium, fastest acting. Rapacuronium, fastest acting, but it is withdrawn. Vecuronium is preferred in cardiac patients because of the cardiovascular stability, but contraindicated in hepatic disease and biliary obstruction, and can still be safely given in renal failure. That is the point you need to remember. Doxycycline, most potent, longest acting. You can remember. In the steroids, which is most potent, dexamethasone. याद है ना? डेक्सा, डी. ये डी से जो भी आता है बहुत पोटेंट रहता है. So doxycycline, most potent, long acting. Just like dexamethasone in steroids is very potent, is what you need to remember. But Maranji, बताइए. See, today's session inspiration comes from Priyanga, who said, sir, anesthesia का रिवाइज करो. दम है तो 3 घंटे में रिविजन करके दिखाओ पूरा anesthesia को, ताकि हम पढ़ने का जरूरत नहीं पड़ेगा. I was thinking, which question bank shall I revise? PGI, AIMS, All India, JIPMER. Every question bank is minimum 400-500 questions है. FMG question bank is only 100 questions in last 15 years. चलो बोल के उसको क्लासिफाई करके आज हम डिस्कस कर रहे हैं, right? So always doctor, the rule in entrance exam is the more brief is your luggage, the more lighter is your luggage, it is easy to fly. Cabin baggage में जितना होता है उतना ही रहना है material आपके पढ़ाई करने का. You don't need to do a check-in. right? So that is how you should prepare. So doctor, in renal failure, muscle relaxant, which one do you use? We use atracurium. Similarly, renal disease, muscle relaxant, cisatracurium. अभी आ गया एक क्विक समरी टेबल, इसको जरा ध्यान से पढ़ना. पीडियाट्रिक succinyl choline should not be used routinely. Please remember, each of this is a single liner MCQ. आपको टेंशन नहीं, ये पूरा पावर पॉइंट इज अवेलेबल इन द onlinemmbbs.com वीडियो लाइब्रेरी. हमारे onlinemmbbs.com वीडियो लाइब्रेरी में हर एक वीडियो के नीचे एक पावर पॉइंट रहता, राइट, और एक क्विज रहता इन एवरी लेक्चर. If you want to be challenged, go through the quiz and then listen. If you want it, you have time and detailed गाना सुन सकते हैं आप, गाना बजाना डॉक्टर मुरली भारद्वाज के साथ वीडियो देखो, मगर half an hour you have to give time. But you want to quickly revise, then PowerPoint will be available for you to do the review. All these PowerPoint slides will be available in onlinemmbbs.com video library. So don't forget to subscribe at a throwaway price, right? So non-depolarizing agents, they have a faster onset. Vecuronium is long-acting in neonates. Elderly, they have a decreased clearance, prolonged duration, except for cisatracurium, which you can give safely in elderly. Obese people, you need to do a 20% more than the lean body weight. Onset is not changed, even if you are obese, if you are using muscle relaxants, but it can prolong duration, except for cisatracurium. Then hepatic disease may, the liver disease may, there is an increased volume of distribution of muscle relaxants. Pancuronium, vecuronium, careful in liver disease because they are completely dependent on hepatic metabolism. Cisatracurium is safe. Any day atracurium is safe, even if your kidney is not there, even if your liver is being sold out. Then pseudocholine esterase is decreased. So that is the reason it leads to prolonged action of succinyl choline in hepatic disease. Why succinyl choline action become prolonged? Because in hepatic disease, pseudocholine esterase levels will fall down, is what you need to remember. Then renal failure may, vecuronium is prolonged, rocuronium is unchanged, cisatracurium is safest. That is what you need to remember. If he is critically ill, if you are using muscle relaxant, then you have to be careful, especially those who have myopathy, polyneuropathy. In them, you have to be careful while giving succinyl choline. So, doctor, what are the drugs whose action is terminated only by purely renal excretion? Please don't forget this list. Galamine, digoxin, inotropes, aminoglycosides, vancomycin, cephalosporins, penicillin, completely dependent on renal. Drugs which are partially terminated by kidney, barbiturates, pancuronium, vecuronium, neostigmin, edrophonium, atropine, glycopyrrolate, hydralazine, sulfonamides. This is the general pharmacology favorite area for the examiner. So, doctor, fastest onset skeletal muscle relaxing. Whatever. 86 online students, keep punching the answers, doctor. Today we should cross 150 before anesthesia revision is over in the live online. That is your promise that you will be my brand ambassadors for attending this free live broadcast and call your classmates. Sri Lakshmi is proposing rocuronium. Priyanka also, very good. It is rocuronium. Hoffman's elimination, cisatracurium. Renal failure, atracurium, Hoffman elimination, atracurium, khatam. If you are spending more than half day, 6 hours से ज़्यादा anesthesia पढ़े तो स्वास्थ्य के लिए अच्छा नहीं है, right? So remember, if you are preparing for the NEETPG or FMG more than 400 hours, that means you are not reading at all. That means you are not studying it. You don't know what to read. That is the reason you are taking more than 400 hours before you say, I am done. Right? So that is the reason always your approach should be 953 topics, doctor. जिसके पास ये टॉपिक लिस्ट नहीं है, हमारे हेल्पलाइन को कॉल करो, अभी मिल जाएगा 9000-868-356. All 300 questions of the examiner inevitably come from this 953 topics because we did an analysis of 30,000 MCQs in the last 15 years and came up in the descending order of the priority these 953 topics. Okay? So, one more thing. Before NEETPG 2020 exam, doctor, I got one more quick idea. FMG Foreign Medical Graduate Exam का 2018, 2019, 2020 हमको 600, 600, 600. Each paper is 300 bucks ना? So 1800 MCQs है भाई. टाइम मिले तो ये 1800 को फटाफट रिवीजन करेंगे. 2018, 19, 20 FMG, क्योंकि FMG NEETPG का छोटा भाई है ना? तो एग्जामिनर वही क्वेश्चंस इधर भी उधर भी एक ही क्वेश्चन बैंक है. So that is the reason it is worth to quickly perusing through these 3 papers. आप सब लोग रेडी बोले तो मैं भी रेडी होके आपको रिवीजन करूंगा, ठीक है? So, what is the purpose of cuff in case of endotracheal tube? That will prevent the regurgitation of the gastric contents. Bhaiya, how does the endotracheal tube look like? There is a soft tip to reduce potential trauma, a high volume, low pressure cuff, so that when you after putting endotracheal tube, if you happen to blow this, what will happen? Endotracheal tube means you are passing it into the trachea, right? So, अगर एक cuff को blow करे तो क्या होता है? It will hold, so that any gastric secretions, if they happen to pass into the trachea, this cuff will form a inflated cuff after putting endotracheal tube. It will be holding the walls tightly so that it will not let the aspiration to happen. So that is the whole purpose. But if you pump too much air and blow this cuff too much, no, it will put too much pressure on the trachea. And for few days, if you keep the ET tube like that only, it can lead to necrosis of trachea. That is a complication which can occur. So that is what you need to remember. Similarly, there is a precise calibration indicating how deeply you have gone. What is a common mistake done by a lot of residents while putting endotracheal tube initial days? Anxiously they keep pushing. If you push, what will happen? It will go all the way and pass into right bronchus, and that will make the left bronchus lose its ventilation, and that lead to development of collapse, atelectasis of the left bronchus. So that is the reason you should only reach until the bifurcation only, not beyond it. You should not push it. That is what you have to be very sure about. So it is a standard 15 mm connector, and this is the above the cuff suction port. This is the balloon, And this is the air-filled cuff typically contains 10 ml. That is what you should remember. Now, what is the advantage of doing a intubation? If it is a cuffed endotracheal tube, number one, it will protect the airway. Similarly, you can get an access into tracheobronchial tree. Then, if the ventilation is occurring via endotracheal tube, देखो endotracheal tube trachea के अंदर गया और here you have connected it to ventilator, then you are not see the air in the ventilator is going into trachea without going into esophagus, so gastric distension will not be there. Otherwise, if you put an ambu and keep doing the ambu with the airway, you are pushing air into the stomach also. So that is the major advantage. Now, doctor, very good. Shweta rightly said, check breath sounds. Very important to prevent too much of insertion of the endotracheal tube. Right, doctor? Now, what is this instrument that you are seeing? It is used for ventilation, endotracheal tube. Laryngeal mask airway. Where is it used, doctor? To maintain the airway. अच्छा भैया, laryngeal mask airway. How do we use it? Very simple. See, doctor, there is a pharynx which typically become esophagus that will go into stomach. Agree? Now, here what you have? Here you are having at the same level में trachea, right? So, what is our main purpose? You don't want these secretions from the stomach go up the esophagus, pass through the pharynx and drop into trachea. You don't want that. So how can you avoid it? Suppose if you place this laryngeal mask and try to above the esophagus, if you happen to block the laryngeal inlet so that you can avoid the pharyngeal secretions to pass into the larynx. So that gateway at the laryngeal airway, blocking it, you use this. So where will you place it? Above the level of the esophagus you will place this so that you are providing a protection to the larynx and trachea. That is the whole idea, doctor. Gotcha? Now, you have a distal aperture. This is the cuff. This is the airway tube. This is the proximal aperture. And you have a pilot balloon valve. So, the laryngeal mask airway is an alternative device to support the airway. It causes less pain and coughing compared to endotracheal. Endotracheal tube बोले तो all the way it will go into the trachea until the bifurcation. It is more easier to insert. Laryngeal mask is only above the level of esophagus only. It is easy to insert. It has an inflatable silicone mask, rubber connecting tube. It is inserted blindly into pharynx and it will form a seal around the laryngeal inlet and it permits a gentle positive pressure ventilation. That is the whole idea. Gotcha? Now, doctor, vareva, khush hua Mogambo, 98, two more classmates, we will cross 100. Endotracheal tube is not useful for what? It is useful for pulmonary toilet, for obstruction. Whenever there is an altered sensorium and a decreased level of consciousness in a case of the head injury or any altered sensorium, we use endotracheal tube, not in pneumothorax. Pneumothorax means you have to do an intercostal drainage tube and suck out the air and let the lung to expand. That is important maneuver. Now, what is the instruction for a routine intubation? head tilt, chin lift, jaw thrust. It is like army command. Attention, stand at ease. Head tilt, chin lift, jaw thrust. You have to be very sure. So, one method, there are three methods. You will be tilting the head, jaw thrust and open mouth. Head tilt, jaw thrust and open mouth. Second method, here also there is a jaw thrust, open mouth, head tilt. This is called lateral way of doing it. Left lateral way of doing it. So the head tilt, why do you do the head tilt? It will stretch the anterior neck muscles. It will lift the tongue away from the posteropharyngeal wall and epiglottis, away from the laryngeal inlet, and the chin lift will stretch the structures more and pulls the mandible and tongue forward. That is how you are securing the airway. And the jaw thrust, it is an alternative to head tilt and chin lift. Especially if you are having a strong suspicion of cervical spine injury, where you can't do head tilt and chin lift, jaw thrust can be, you can still do jaw thrust. So that is a point you need to appreciate. What is true about laryngeal mask airway? It maintains the airway. Mallam Patti classification. You have to be very sure, doctor. You are about to do intubation. मगर आपका पेशेंट कौन है? गब्बर आ गया, शोले मूवी का गब्बर आके लेट गया. डॉक्टर एंडोट्रेकियल इंटुबेशन करो. कितने गोली है डॉक्टर बोल के पूछेगा. गब्बर का मुंह खोले तो आपको कुछ भी नहीं दिखा रहे, खाली टंग दिखा रहे. So what Mallam Patti? It's very difficult to intubate, right? So class 1 means if you can see complete visualization of soft palate. Class 2, complete visualization of the uvula. Class 3, visualization of only the base of uvula. And class 4, soft palate is not visible at all in gabbar. That is what you need to remember. So that is the reason pre-anesthetic evaluation. You are planning to post the person for surgery. Some people will have short neck. You have to be well prepared in an elective intubation. So Mallam Patti score will tell how easy or how difficult it is to do the intubation. Now, this is pro-seal type laryngeal mask. Pro-seal laryngeal mask. Where will you put this laryngeal mask is the examiner's question. अभी बताओ, अब भी डिस्कस किया ना, फटाफट बोलो. Question number 32. Mohan Babu says above esophagus. Above esophagus. Excellent. So pro-seal laryngeal mask airway is a modification of the classical laryngeal mask airway. Mainly, it will make any gastric contents. The laryngeal inlet is guarded by this laryngeal mask, so that the secretions of the stomach will pass into esophagus and they don't enter into trachea. So that is the idea. So typically this is the tongue, doctor. This is the tongue. Okay, this is the tongue. Then you are having the drain tube, and this is the trachea, and this is how you put a laryngeal mask airway correctly placed. So it has a 15 mm connector, bite block, inflation line, a flexible 9 mm internal diameter airway tube. There is a pilot balloon, and there is a drain tube and an inflatable cuff. That is what you need to remember. This is a highly prospective potential image-based MCQ. In the tomorrow's NEETPG exam, doctor, you have to be very sure. So if you correctly place a laryngeal mask airway, the distal opening of the drainage tube is wedged against the upper esophageal sphincter, so that it is preventing the escape of the inspired gas through the drainage tube, is what you should remember. So this is how you pass the laryngeal mask airway, and this laryngeal mask airway is acting as a seal against the laryngeal inlet, which is becoming larynx become trachea, become bifurcation. So it is guarding the laryngeal inlet is what you need to remember. So Pro Seal laryngeal mask airway. It is silicone made. And what are the important modifications compared to classical LMA? There is an esophageal drain tube, posterior inflatable cuff, reinforced airway tube, integral bite block, introducer, ये सब चीजें हैं इसमें. So this is how a classic look like. This is a Pro Seal additionally, and this is called flexible one. So this is how the different types of laryngeal mask airways is what you should remember. Dr. क्रिकोथायरॉटमी के लिए एग्जामिनर आपसे पूछ रहे हैं, भैया ये नेक में एडम्स एप्पल क्या है, एडम के पीछे क्या है, एडम के नीचे क्या है, मालूम है क्या बोल के पूछ रहे हैं. This is the sternocleidomastoid. This is the thyroid cartilage. And what is this? What is this, doctor? This is the cricoid cartilage. Cricoid cartilage. That is what you have to emphatically identify the classical landmarks in the neck. Now, doctor, inhalational anesthetics. Which drug is used to control the secretions of the general anesthesia in pre-anesthetic medication, which is anticholinergic, like glycopyrrolate is what you should remember. So, fatafat batao doctors, what are all the pre-anesthetic medications? Pre-anesthetic medications. Good. Keep punching answers, doctor. Anticholinergics will dry out the secretions of the fluids. Benzodiazepines relieve the anxiety. Thiopentol, propofol are used for rapid induction. You will give an antiemetic, antihistaminic to prevent allergic reactions because of the release of the histamine by the muscle relaxants. You give H2 receptor blockers to reduce GI motility and opiates to induce the analgesia is what you should remember. So doctors, what are the adjunctive medications? Benzodiazepines, anxiolysis, amnesia. H2 blockers, ranitidine, prevent gastric acid secretion. Atropine, glycopyrrolate, they prevent bradycardia and they dry out the secretions of fluids. Suxamethonium, neuromuscular blocker. Fentanyl relieves the pain, and antiemetic to prevent post-operative vomiting is what you need to remember. So what are the antiemetics that you use? Ondansetron for analgesia, paracetamol, opioids. Anticholinergics can be scopolamine or glycopyrrolate are very much used is what you need to remember. Now doctor, anesthetic agent of choice in a pediatric patient. पीडियाट्रिक को हिंदी में क्या बोलते हैं? शिशु. शिशु छोटा शिशु है. शिशु को आप क्या दे सकते हैं? एस फॉर सिवोफ्लोरेन दे सकते हैं, राइट? सो दिस इज हाउ सिवोफ्लोरेन टिपिकली लुक्स लाइक. It is the first agent of choice in pediatric anesthesia and second agent for asthmatics, cardiac anesthesia and neuro anesthesia. छोटे नन्हे मुन्ने बच्चे को सिवोफ्लोरेन क्यों देते हैं? उसका क्या प्रॉपर्टी उतना स्पेशल बनाता है? एयरवे इरिटेशन among all the available volatile agents makes it a wonderful induction agent of choice for inhalational anesthesia is what you need to remember. It will not sensitize the myocardium. शिशु का दिल बहुत नाजुक होता है, एरिथमियास जगाएगा नहीं. It does not result in carbon monoxide production with dry soda lime. That's what you need to remember. So it is well tolerated, rapid induction, rapid recovery, does not sensitize myocardium, does not produce carbon monoxide. Now let us talk some special points. Sevoflurane, isoflurane, desflurane. They have anticonvulsant property, good for epilepsy. Right? Remember, SID, epilepsy, side. Sevoflurane, isoflurane, desflurane, good for epilepsy is what you should remember. Enflurane, not good for epilepsy. E is not good for E. Enflurane interacts with soda lime but produces very little carbon monoxide. Ketamine is an NMDA antagonist. N-methyl deasparated receptor antagonist is ketamine. Propofol, smooth induction, rapid recovery. इसलिए डे केयर सर्जरी में propofol is the one which is preferred, is what you should remember. Desflurane, pungent odor, pungent odor. Desflurane, dirty odor, desflurane. Right? It leads to airway irritation, breath holding, coughing, laryngospasm, and of all the agents which produce highest carbon monoxide, desflurane. That is the reason it is dirty. But entrance exam में examiner के लिए it is a favorite question, right? Now, fastest acting inhalational agent क्या होता है? Sevoflurane. So, what decides whether anesthetic is fast or is slow? Is slow है या fast है? कैसे? What is that property that decides? Blood gas partition coefficient. It is a measure of solubility of a general anesthetic. It is the one which decides whether an anesthetic will be fast or slow. Okay? So let us look into the various agents, doctor, and their blood gas coefficient. Xenon more than desflurane, more than cyclopropane, more than or less than? It should be less than, right? It should all be less than. N2O, no. Blood gas partition coefficient is inversely proportional to the onset of action. See, onset of action of anesthetic, how will it occur? बताओ. एनेस्थेटिक दिमाग में जाना. कहां से जाना? ब्लड से दिमाग में जाना. It should go into brain from blood. Agreed, na doctor? How will it go from blood into brain? What is the driving force? What is its partial pressure? Now, suppose if it is highly soluble in blood, right? It will never achieve a partial pressure. So, less the solubility, greater will be its partial pressure. Rapidly it will go to brain and onset of action will be rapid. और एक बार बोलो, less the solubility, greater will be the partial pressure of it in the blood because it is insoluble, and it will go into the brain very fast. So that is the reason you should remember, lesser the blood gas partition coefficient, lesser is the solubility, greater is the partial pressure of it, that will make it to enter into the brain faster. So xenon का lowest blood gas partition coefficient, least soluble and fastest to go into brain, because it will achieve partial pressure very fast because it is not soluble. Barabar? Then desflurane. Next, cyclopropane, then N2O, then SIVO, then ISO, then enflurane. Then halothane, chloroform, trilene, trichloroethylene, ether, and slowest in its onset of action will be methoxyflurane, because it has highest blood gas partition coefficient. That means it is highly soluble. That means it can't achieve the partial pressure. That is what you need to remember. समझ में आ गए ना? और एक बार मेरे साथ रिसाइट करो. लोअर दी, कम ऑन, हमारे मुंह की बात छीन लो. लोअर दी blood gas partition coefficient, right? Lower the solubility, higher will be the partial pressure, faster will be the entry into the brain, rapid will be the onset of action. That is what you need to remember. Now, doctor, what are the various inhalation anesthetics? Sevoflurane, it has a low pungency without irritating the airways, good in pediatrics. Sevoflurane after desflurane has fastest onset and offset. Then sevoflurane is metabolized in the liver, but those metabolites can be nephrotoxic. They can cause an increase in intracranial pressure. If the fresh gas flow is low, that is the reason. How will you set up the anesthetic equipment settings? Fresh gas flow should be little faster whenever you are giving the sevoflurane, is what you need to remember. Whatever, हम तो century 100 online students, हम बहुत खुश हैं. Now, Dr. Halothane. Halothane is potent, non-inflammable, non-toxic, colorless liquid, non-pungent vapor. But halothane जो है ना डॉक्टर, least analgesic. Halothane लिए तो इतना भी pain कम नहीं होता. That is the point. Opposite is N2O. Nitrous oxide, very good. पूरा pain निकल जाता. मगर it doesn't have anesthetic action. Right? Then halothane is a bronchodilator, uterine relaxant, vasodilator, anesthesia of choice for uterine contraction and inversion. If the patient has a uterine inversion, a pregnant obstetrical complication, then you will give halothane, is what you should remember. Now, doctor, anesthetic agent not metabolized by the body. Nitrous oxide is not metabolized. So nitrous oxide acts on the body by moving across the partial pressure gradients. It can cross the alveolar membrane easily. It is insoluble, and the clinical effects will start in 3 to 5 minutes. And elimination is rapid. It is not metabolized. That is what you need to remember about laughing gas. About halothane, what is except? We use amber colored bottles for halothane. It is erythmogenic. दिल के लिए, heart के लिए halothane अच्छा नहीं है. Hepatitis, if you are repeatedly using it in adults only. Halothane hepatitis is not that much a problem in case of children. And it is a bronchodilator. That's the point you need to remember. So halothane, 20% is metabolized. Spontaneous oxidative decomposition of it will occur. That is the reason you have to keep it in dark. amber glass containers with thymol as the preservative is what you should remember. So about halothane, what are the therapeutic uses, doctor? It is potent anesthetic but a weak analgesic. इसलिए इसका शादी किसके साथ होता है? नाइट्रस ऑक्साइड से. Nitrous oxide is a potent analgesic but a weak anesthetic. Similarly, it is a bronchodilator, halothane. Relaxes both skeletal and smooth muscle and uterine muscle. No hepatotoxicity in children. Suitable in pediatrics for inhalational induction. So, sevoflurane is now the choice. That is the point you need to remember. Mayer-Overton rule. Where do we use Mayer-Overton rule? Is an important question. We use it for inhalational anesthetics, doctor. Mayer-Overton rule. So, what does Mayer-Overton rule say? Mayer-Overton 1903 में 120, 115 years के पहले क्या बताया? There's a strong correlation between the solubility of any anesthetic gas in the olive oil and the anesthetic potency. So that is how the lipid bilayer water partition coefficient and the potency के बीच में relationship है बोल के Mayer-Overton साहब ने एक जमाने में बताया. So that is what you need to remember. Now what is the anesthetic of choice in pediatric population? Sevoflurane. Which is fastest acting inhalational agent? Sevoflurane. Sevoflurane का भजन खत्म. The next topic in FMG question bank is succinylcholine. So doctor, once more, once you are doing this revision, please don't forget in the online mbbs.com video library में अगर आप anesthesia 30,000 hot MCQs बोल के एक फोल्डर रहता, वहां गए तो आपको एनेस्थीसिया में DNB का क्वेश्चन बैंक, एम्स का, ऑल इंडिया का, ये सब क्वेश्चन बैंक्स they have been topic wise classified, debated, discussed and made available. So please take a chance. Only selectively those topics which you feel I need a little more, you can go back and do the revision. Right, doc? So that is the whole idea. Our live online interactive sessions are supposed to be catalysts, extra energy for you to go back to the bank and the video library and do the revision and preparation every day. रोज डॉक्टर मुरली भरद्वाज के साथ 1 to 2 hours spend करो live online में along with all classmates across country and spend another 3 to 4 hours on the online mbbs.com video library. Every Sunday take a grand test and discussion. Every Saturday subject test and discussion. Stick to this. If you don't get seat, मेरा है जिम्मेदारी. ठीक है? So tell your juniors to subscribe to online mbbs.com video library. Now doctor, malignant hyperthermia. What is it because of? It is a problem in rhinodine receptor. This was the FMG 2017 का question है. So malignant hyperthermia is an inherited disorder. So a rhinodine receptor का story क्या है? Typically, rhinodine receptors, they modulate the calcium release from the sarcoplasmic reticulum. So, let us look at excitation, contraction, coupling का story क्या है. हम बहुत बार इसके पहले फिजियोलॉजी में डिस्कस किया, अभी भी करेंगे. भैया मोटार न्यूरॉन आके एसिटाइलकोलिन का रिलीज करेगा सिनेप्टिक जंक्शन पर. Acetylcholine will go and bind with the acetylcholine receptors and it will open the sodium channels. Sodium channel open होते ही action potential zoom stroke आ जाएगा, upstroke. Then the action potential is propagated in the T tubule. Yeah, दिख रहे हैं ना? T tubule दिख रहे हैं ना? हाँ. Then you are having the voltage sensor dihydropyridine receptors. I mean the rhinodine receptors. So these are the ones which are activated across the T tubule when there is a prolonged propagation of the action potential. Then that makes the calcium to get released from the smooth endoplasmic reticulum via rhinodine receptors. So that will make the calcium release from the sarcoplasmic, from the smooth endoplasmic reticulum. That is the function of rhinodine receptor. Then that released calcium will bind with the troponin to facilitate actin-myosin complex. Then smooth endoplasmic reticulum calcium propels the calcium back into the sarcoplasmic reticulum, and it causes the relaxation when the calcium levels fall down, and for this it requires ATP. So we require energy to relax, not to contract the muscle. We require it for relaxation. ATP का जरूरत कहाँ होता है? मसल कंट्रैक्शन में मसल को रिलैक्स होने के लिए जरूरत पड़ता है. इसलिए अगर हम मर गए तो ATP प्रोडक्शन नहीं होता, अगर नहीं है तो रिलैक्सेशन नहीं होता, इसलिए कंट्रैक्शन कंटिन्यू होता, एंड दैट इज हाउ हमको होगा rigor mortis is what you need to remember. Barabar? So these are the 7 steps that you need to be very, very sure about, doctor. So Vyom Chaudhary bol rahe, rhinodine is also implicated in congenital myopathy. Absolutely, doctor. So you have a calcium releasing unit which is very important for excitation, contraction, coupling, excitation of the nerve and contraction of the muscle. It includes rhinodine, which interacts with the calcium and other proteins. So what are they? Homer 1, calstabin, triadin, juntin, juntophyllin. They're all the various other calcium proteins. And any malignant hyperthermia, there is a problem in rhinodine. What is the problem in rhinodine? Normally, rhinodine receptors will make the calcium released from sarcoplasmic endoplasmic reticulum, smooth endoplasmic reticulum, only when the nerve brings action potential. But in the people who have malignant hyperthermia, even though the nerve is not releasing acetylcholine, even though acetylcholine is not binding to receptor, even though sodium channels are not generating action potential, even though there is no action potential, propagated in T tubule, even though there is no dihydropyridine receptor activation, without anything only, this mutant rhinodine receptors continuously will make the smooth endoplasmic reticulum to keep on releasing calcium, keep on leaking the calcium. That will make unnecessary contraction of actin and myosin. That is called malignant hyperthermia, is what you need to remember. Got it, doctor? So this is the favorite batti marne wala cheez aa gaya. What are the triggers for malignant hyperthermia and what are not triggers so that it can be safely used? Favorite question of the examiner. Halothane, sevoflurane, desflurane, all these potent volatile anesthetics are all triggers. Succinylcholine also. Whereas intravenous agents, not inhalational, intravenous anesthetics like ketamine, vagera, opioids, non-depolarizing agents like curare derivatives, ketamine, propofol, anxiolytics, they don't trigger the Malignant hyperthermia is what you need to remember. Now, doctor, which drug lead to malignant hyperthermia? Obviously, examiner EC ke upar बैठ के he will keep drumming you. What is your answer? Succinylcholine. Malignant hyperthermia is caused by ryanodine receptor. Now comes the succinylcholine. Succinylcholine. Succinylcholine is the shortest acting muscle relaxant because there is a pseudocholinesterase which will break down the tail. It will cut the tail of succinylcholine. It is responsible for post-operative muscle pain. Why? What is succinylcholine doing, doctor? What type of, is it depolarizing or non-depolarizing? देखेंगे कितने लोग awake and how many of you are sleeping? Tell me, doctor, succinylcholine depolarizing, non-depolarizing? अगर wrong answer, एक भी wrong answer बताए तो I will cry. Come on, quickly give me the answer. Yes. Shweta is saying neostigmine antagonizes only non-depolarizing or depolarizing? Priyanka, tell me. Very good. Rampal Singh, Jagadishwari, Shweta, Indrani, everybody is saying depolarizing. Abba, bach gaya. So, doctor, typically if you give succinylcholine, what is it doing? Succinylcholine क्या कर रहे हैं? Succinylcholine आके बोलेगा भैया एक एसिटाइलकोलिन के लिए क्यों वेट कर रहे हो? मैं हूं ना, मैं आ गया ना. एसिटाइलकोलिन के जैसे ये भी सोडियम चैनल को ओपन करेगा. It will open the sodium channel. That immediately will lead to depolarization of this postsynaptic membrane. Then when acetylcholine actually comes, this is already in a depolarized state. It already married the America Sambandham. It is no more available for his classmate to propose love anymore. This one. Right? So, whenever depolarization occurs, immediately what will, even if it is caused by succinylcholine, if the depolarization occurs, what will it lead to? It lead to sudden muscle contractions. That lead to fasciculations. So once you give the succinylcholine, initially it lead to quick depolarization leading to fasciculations. That is the reason post-operatively they will have muscle pain is what you need to understand. So succinylcholine, how do you manage the apnea of succinylcholine? Yeah, few people, how is succinylcholine is metabolized, doctor? Okay, it is a muscle relaxant. How will it get metabolized? Pseudocholinesterase will come and break it down. In few people, as I told you, genetically have a low pseudocholinesterase. So it is no more metabolized. So what will happen in that situation? Muscle relaxation continues. The diaphragm continue to remain relaxed. So that lead to apnea. So now the question is, how do you manage that? How do you manage that? You should continue ventilatory support and you can give fresh frozen plasma. Fresh frozen plasma which is having the cholinesterase that you can be able to transfuse in order to overcome the succinylcholine apnea is what you need to remember. Now, which is not an effect on suxamethonium. What are all the complications? Suxamethonium is same as succinylcholine. पहला वो समझ लो, हाँ? जरा टेंशन नहीं रहना. Suxamethonium, succinylcholine दोनों एक ही है. Trilene, trichloroethylene एक ही है. Like cochin and kochi, huh? So now, doctor, hyperkalemia, increased intragastric pressure, myalgia. These are the effects of suxamethonium. So फटाफट बोलो डॉक्टर, all the list को भूलना नहीं. Suxamethonium lead to myalgia, it can trigger malignant hyperthermia, it can lead to spasm of the masseter, it lead to phase 2 block, rises intracranial pressure, rises intraocular pressure, it can lead to bradycardia, usually in infants. Succinylcholine is like acetylcholine, na doctor? Acetylcholine क्या करता है? Bradycardia, not tachycardia. Similarly, it raises the serum potassium, especially those who have denervation, burns patient, muscle injury patients. In all those people, it leads to significant hyperkalemia. And those who are having pseudocholinesterase deficiency genetically, it leads to prolonged apnea. It can lead to histamine release. It can lead to 1 in 5,000 patients may anaphylaxis can occur. So there are all the challenges with suxamethonium. और एक बार बोलो, fasciculations, hyperkalemia, myalgias, myoglobinuria, raised IOT, raised ICT, raised intragastric pressure, trismus, malignant hyperthermia trigger. You should not forget succinylcholine. Now, which drugs will lead to malignant hyperthermia, doctor? Desflurane, isoflurane, sevoflurane, they are all implicated in malignant hyperthermia. So that is the reason, don't forget what are safe drugs in malignant hyperthermia susceptible patients. Barbiturates, propofol, etomidate, ketamine. Right? Is the video frozen, doctor? Abba. Our video sometimes suffers myasthenia gravis. I refresh the broadcast. Please be online, doctor. I am refreshing the broadcast. Good, good. We are all back, doctor? Yeah. So what are the drugs which are safe in malignant hyperthermia is a very important question. So you should once more remember, doctor. Barbiturates, propofol, etomidate, ketamine, benzodiazepines, amide and ester local anesthetics, non-depolarizing muscle relaxants, calcium, nitrous oxide, safe in malignant hyperthermia. Definitely asked the question. Now, what are drugs triggering depolarizing muscle relaxant like succinylcholine or volatile anesthetics? Ether, not nitrous oxide. Ether, cyclopropane, methoxyflurane, halothane, isoflurane, enflurane, sevoflurane, desflurane. They're all triggering is what you need to remember. Succinylcholine, what does it lead to? Now you are experts. Severe hyperkalemia. Succinylcholine causes hyperkalemia, especially in those who have nerve disorder, muscle disorder. So those who have nerve disorder, it is contraindicated. Like those who have paraplegia, hemiplegia, Guillain-Barré syndrome, it is contraindicated. Similarly, muscular dystrophies, myasthenia gravis, crush injuries, burns, rhabdomyolysis, it is contraindicated. Now, which agent lead to malignant hyperthermia? Succinylcholine. That is the story, doctor. I know what Shweta is going to tell. Oh no, is the class over? I don't know how it is over. Am I right, Shweta? Right? So, I always cherish some of your comments. That you unknowingly there will be a kind of a attachment that forms, especially those who regularly interact. We all interact on the YouTube. So it is not yet over. It is not yet over. So another 50 questions are there. 100 questions totally in the last 15 years. FMG क्वेश्चन बैंक एक काम करेंगे अभी 3:45 हो गया ना डॉक्टर सो जरा हम कुछ लंच करके 4:30 p.m. we will restart part 2. We will take another 1.5 hours to complete the remaining 50 questions and the important points associated with that. Okay, so just have a little break and then rejoin at 4:30 p.m. See you, and let us all revise. Next 9 days, very crucial period. Let us be in full energy. That too, when you are with Dr. Murli, only energy. Born Vita. See you.